Welcome to Life in Sirens, Behind and on the Scene, a podcast by first responders. We're your hosts, Sophie,
Jamie,
and Aubrey.
The content provided in this podcast is for informational and educational purposes only and should not be considered medical advice. The views and opinions expressed by the hosts and guests are their own and do not necessarily reflect the official policies or positions of any medical institutions, emergency medical services, or healthcare organizations. Patient privacy is a top priority, and all discussions involving real-world emergency situations are de-identified and altered to ensure confidentiality. Always consult with a qualified healthcare professional or your local EMS protocols before making any decisions regarding patient care or medical practices. Listener discretion is advised, as some topics may include discussions of real-world emergency situations. Welcome.
Hey, it's us. We're just real tired.
We are here.
We're going to talk about what do you do when the heart won't cooperate? Pacing, pacemakers, and AICDs.
Our goals of this episode are going to be to identify clinically significant bradycardia, obviously.
Mm-hmm.
It's kind of the whole deal. Knowing when to pace, how to pace. We're going to talk about implanted pacemakers and if they may unfortunately malfunction, and defibrillators as well, including those that are implanted. For the record, we don't have to be electrophysiologists. We just need to understand when perfusion is failing and when we need to act quickly with a very scary intervention because it's not one we use a lot.
Yeah.
So let's dive in, I suppose. So, do you want to talk about bradycardia first?
Yeah.
What is it?
Slow.
Sleepy hearts.
Sleepy hearts.
Bradycardia is heart rate under 60. But what it... Okay, but it's more than that, right?
There's like a few
Get
other
outta
nuances
here.
to it. Yeah.
Nope, that's it, right?
Nope.
Because when their heart rate's 59, what do? We
Pace 'em.
panic.
Atropine. Oh. See, we're not even all in agreement.
Exactly. So there is more nuance to it. We know. We're just
You're
being
right.
silly. It's
You're right.
fine.
You're right.
Silly little gooses.
Usually, true bradycardia is a heart rate below 60 with some other symptoms, right? And probably signs of poor perfusion. Your rate alone isn't
Yes.
significant enough
For sure.
to treat a patient.
Yes,
right?
like my resting heart rate is like 55.
Me too.
Please don't pace me.
Please don't freaking pace.
I'm chilling. Yeah.
That
I
would be
think-
weird, bro. Don't give
I
me atropine either.
Right. I think
God.
bradycardia for me is the best example of treat your patient, not your monitor.
Yeah.
Like the best example. Because if you just go by like, oh, they are clinically bradycardic,
You would be treating so much bradycardia.
so much.
Oh my goodness.
So much. And people have to be like truly sick because of it to actually treat it.
So what might cause someone to be bradycardic and stable? What are some things?
Lithium. I know that is so random.
You said that wildly.
But it can.
But yes, medications,
Okay, got it.
Lithium, beta
beta
blockers.
blockers,
Mhm.
rate controllers in general, a very active and physically fit person, someone
Yeah.
who does a lot of cardio. There's plenty of reasons,
Yep.
right? So now that we know some of the reasons they could be benignly bradycardic, what are some of the determinants of like instability?
Well, the biggest one is altered mental status.
Yep.
Yeah, that's a very scary one.
Hypotension, hypoxemia, lack of perfusion in any way you want to measure that.
Yeah.
Yeah. Any signs of like acute heart failure?
They really look sick. They
Yeah.
they almost always look so sick.
Yeah.
Pale, diaphoretic sometimes.
And bradycardic patients are almost always lethargic.
Yeah.
They're not like that anxious and like jumpy. Yeah. They
Vibrating.
most of the time are pretty sleepy.
100%. Other than we've talked about medications and other things that could possibly benignly cause bradycardia, what about the big scary things that cause bradycardia?
Heart blocks.
Yeah.
Big ones.
Myocardial infarctions.
Overdoses
Yeah.
on
Lots
Beta
of medications.
blockers. Lithium.
Yeah.
Mhm.
overindulgence in drugs,
Yeah.
accidental or intentional.
Either way.
Hypoxia.
Mm-hmm.
There's all kinds of things.
If you are already bradycardic because of your hypoxia,
Oof.
ooh.
You better get the pads on them regardless.
Yeah, we're in a bad way.
Okay, we talked about the less scary things. We talked about the more scary things that could cause this. And Aubrey brought up heart blocks. So other than just sinus bradycardia, what other heart blocks, or what heart blocks, I should say, would cause bradycardia?
So second degree type 1, second degree type 2, or a complete heart block, also known as a third degree heart block.
Mm-hmm.
And I think that this is going to segue into one of Soph's favorite soapboxes, which is, when do you give atropine and when do you not?
Yeah.
So, if you hit the second degree type 2 for sure or higher, you probably need to consider pacing. They're really freaking sick and they look really sick usually.
Mm-hmm.
But the way atropine works, I have seen a lot of people go into cardiac arrest when you administer atropine, and I mean that. This is anecdotally, but like
You really have.
I get a lot of bradycardic patients, a lot of cardiac patients. It's just like the flavor that I constantly get served up. But there's a reason why we don't just give atropine for everything, and why the guidance of just give atropine and see is very flawed guidance and dangerous guidance. And this is something I could talk about forever. I'll spare you because I think we have a video on this. No, we might have I have a whole episode about it.
Yeah.
That I made.
Yeah. You did.
I really am serious about it. Because what is atropine working on? Okay, it can't get the information. It's like yelling down a hallway where all the doors are closed and locked. And you're expecting for the people to hear you to escape the fire, right? They cannot hear you. So why are you even yelling at them? That's what atropine does.
And I think also understanding like truly the mechanism of atropine is it's a parasympathetic, and so it blocks your muscarinic receptors. So basically it is all about vagal tone and vagal inhibition.
Yes, and if you do that to someone who has nothing left, you do as a murder.
Absolutely. And your problem is not vagal tone. It's not excess vagal tone. That's not why you're bradycardic. And so you're going to increase the SA firing or even like the AV conduction, but that's not where we're failing. And so it's kind of
like
it's not helpful.
If you had those little cups with the string, the fake phone, when you're in higher degree blocks, it's like cutting that string, right? You can send the signal, but it's not going to get to where it needs to go. Atropine works when the signal is like low or sleepy, not when it's severed.
Yes. I think that's a fantastic way to put it. Yeah.
I'm so sorry. I just zoned out because I was trying to look at the newest bradycardia algorithm, and it says nothing about not giving it says like literally if bradycardic, give atropine always.
Yeah.
It does say that, and there's not a ton of studies out there, but the studies that have been performed are very evident that you should not
do it.
Be doing it because it can cause sudden cardiac arrest.
Yeah.
But I thought that the AHA, I thought they had like a basically a disclaimer that was like atropine is
not indicated in high degree. They have more comprehensive than just like the flow chart.
Okay.
So like if you're in a complete heart block or you're past that, so like atropine works on your SA node. Well, once we're in like a second degree type 2 or a third degree, our SA node is out of there. It's not doing anything. It is no longer connected to the rest of the heart.
Yeah, and all you're doing is increasing your atrial rate, and there's no ventricular response. So when you increase just atrial rate, it's like demanding more oxygen to what?
To nothing.
To nothing.
Because
it's like,
the ventricles are not pushing blood to the body, which is not returning blood back to the atria. So eventually you end up in this like not great situation. Also, once you get past your SA node, now you're relying on your AV node, which atropine can work on very minimally.
Yeah.
But like not with great effect. And then after that, you're past your AV node. Now you're into your ventricles. And so you're into your Purkinje fibers and like some of your pacemaker cells down there. And your problem there is that they are not reliant on acetylcholine. And so atropine like truly has no effect at all.
Yes.
And so all you do is increase your oxygen demand by giving it.
It's kind of like when we were just giving dopamine for everything, and it's just like a kick drum to the heart.
Yeah.
Like we're just sending a message that it's like yelling at somebody in a different language, and they're just like, what do I do?
What do I do?
Also, fun fact, if somebody has had a heart transplant, atropine will never be effective on them. Never, not one time.
Nope.
And if they have a heart transplant, they're bradycardic.
We have bigger fish to fry.
No.
This is what I was saying. You'll still be scared even
And
when you're a
I
grown-up medic.
guarantee you, if they are a transplant patient, your specialty hospital, your regional specialty hospital that performed that transplant, they will have that surgeon on speed dial.
Call the call the facility.
Yeah, your patient will be like, call them.
Yeah, they might even have their number.
Be
Yeah.
tattooed on their body.
For
Mhm.
sure.
So we talked about when not to use atropine.
Yeah.
And which makes sense of when we should use it, when it is low degree block and just follow your ACLS in this situation, and they're not having significant signs of decompensation.
Right. And when you, like, if you have someone that is like a soft pressure, but not like super hypotensive,
like, oh,
but
that might be the problem. You're
Yeah.
trying to like
and you
figure
you
things out.
suspect that it's because of an increased vagal tone.
Mhm.
That's a great time.
Just, it's a gentle fix. Yeah. Unless they're so far down the line, then it's a very scary thing.
Mhm.
And it just kept happening to me in Austin. I have had the misfortune of pacing many times in my career so far. Because
Mhm.
literally everybody is just having a low heart rate with me. So what are indications for pacing? Obviously, symptomatic bradycardia, but what does that entail?
Well, kind of what we already went over. Any signs of hypoperfusion, any altered mental status, significant hypotension. This would be a great patient to get end title on.
Absolutely.
Wink,
Any
wink.
indication of heart failure, so any kind of like pulmonary congestion or anything that you're noticing.
Yeah.
100%. Basically, they're probably going to look scary.
They're going to look sick.
They're going to be a sick patient. Absolutely. When we're getting ready to pace, what are some things that could be going on simultaneously while we're setting up? So this episode is basically what we're going to learn how to pace in this episode, right?
Absolutely.
So other than the obvious of placing the pads on this patient, what do we need to do?
You need to get access. So establish
100%.
some kind of vascular
Let's
access.
get 2 if we can.
Yeah, as many as you can, really. No, I'm just kidding. 2's good.
One
Two's
in their
enough.
forehead,
Yeah.
one in both ACs, one in both feet. Just kidding.
Yeah,
At
2.
least probably 2, I would say.
Yeah, 2's good. And start considering sedation.
What should we be doing while... So, this is the thing about paramedicine, right? There's about 1 million things that are probably going to be going through our head.
Mhm.
What are some reversible causes we could be thinking about, even if we have to initially start
Yeah.
pacing them to stabilize them?
Hypovolemia,
Yeah. Okay.
right? Start getting some fluid in there. See if a fluid bolus helps.
Absolutely.
Like a potential overdose.
Yeah.
Hypoxia.
Yes.
Make sure we are
hypoxia.
correcting any kind of hypoxia.
Electrolytes.
Yeah.
Hyperkalemia.
Yeah.
That's a scary one.
It is a scary one.
But there are things we can do to help improve this patient. Right? See, pacing is not the thing that fixes them. It's the thing that helps them get to the point of fixing,
Yeah.
right?
I think that this in our brains is implied, but a 12 lead.
Please do it, hopefully.
Oh yes.
Get a 12 lead. Also, most monitors, the way they're set up is you have to at least have the 4 lead on to be able to read the electrical activity, to be able to
You should please
synchronize it.
put them on the monitor if you have the pads on.
Yeah. So go ahead and get a 12 lead while you're doing that, because that's where you can identify some of your reversible causes.
Yeah, and you don't have to do all this. You have a partner, right? So this is definitely one of those situations. If you just have you and your partner or whatever, do not load and go. Stabilize.
Yeah, you got to get things done.
We got to stabilize them. Are there any situations where you might delay pacing your patient?
If they are showing all of the symptomatic bradycardia things.
Yeah.
I would say if even with them being symptomatic, if the interventions that you have provided prior to pacing they're starting to show improvement. So if your reversible causes, if you've started to address those while you're setting up for pacing, and we've started to have an improvement in mentation or an improvement in perfusion, I think it's appropriate to delay at that point if you think these things are heading in the correct direction.
Yes.
But in the situation of like heart blocks, things like that, those are non-reversible for us. And so, no.
Thanks. Sorry, I just wanted to ask a trick question, and Jamie was not tricked. Yeah, I think that's great. There are times where you should, take a minute, reevaluate. There's some times where we just have to move a little bit aggressively.
So what if they're awake?
So I think that every patient's different. Sedation and pain management is important for this patient. We do not need them bearing down more.
Yeah.
But I think there are plenty of scenarios where you start pacing them and then you say this is going to hurt for a minute, and then we get all the other things on board.
For sure.
The patient's,
the patient's life initially is much more important than their comfort.
Talk to them, tell them what you're going to do.
Yes.
There's a good chance that they are going to at least be altered, though.
Yes. Yeah. And that does not mean that we do not address comfort later on. But you have to be alive to care about if you're comfortable or not. So we got to address that first, and then we can move on to comfort. Yeah, but what about if they're like super old? Like old.
Are you talking about like what we should choose for medication?
Do
if they're super old, check to see if they're DNR.
Right.
I'm serious.
Yeah.
Like if they're in a nursing home, do they have,
For real. They might not want
they might not want to be paced.
Yeah, they might not want to be electrocuted repeatedly.
I think also when we're pacing people, identify if they have an internal pacemaker.
Yes. Now, if they do, can I still externally pace them?
Absolutely. We're going to take a quick detour here because this is a very interesting case I had.
Ooh.
And I probably have told you guys, but I had a patient who got home after an ablation was performed, but they had an internal pacemaker defibrillator as well. The wife called for a fall. We got there. This man is pale, diaphoretic, and altered. He did fall, but it was because he was having a medical emergency. And his initial his hot weight was 33. And so I put him on the monitor immediately, like obviously when I put the probe on him and see that.
Mm-hmm.
And it's just sinus bradycardia. But I'm like, this is weird because he just had an ablation today. What is going on? It is just me and another very small partner. It is the middle of the night, and a fire did not automatically come to our calls where I was working. So we had to get pretty creative on how to get this patient in an upright position. So once we did sit him all the way upright, his, like a little bit lean forward, I would say, his heart rate improved.
Oh my God, did his internal pacemaker like reconnect?
Every time so it was more than 90 degrees. He was like, he had to be like almost like
tripoding,
leaning
forward.
over, like his head had to be like over his knees. So it was really uncomfortable for him. But as long as he did that, his pacemaker was working.
It made contact.
Right? So must have, when they went in for this ablation, they may have,
knocked some
wires loose. But it was very interesting. So understand that is a rare thing that happens, but it obviously does happen.
Yeah, if someone has a pacemaker and they are bradycardic, that pacemaker has clearly failed.
Yes.
So, now it's your turn.
Absolutely. And you could see the pacer, you could see his pacemaker was working when he leaned forward. So it's definitely that. And we got to the hospital, and I explained this to the doctor, and he thought I was just full of shit.
Mm-hmm.
And he laid the patient flat. And then he realized that I was right. But just saying, things like that can happen. I'm not saying to contort your patient, but we just happened to find out.
Yeah.
While we were trying to sit him up to put him on the stretcher. That's wild. That is what was happening.
That is wild.
That is
wild. Crazy.
Oh my goodness. Yeah.
Sorry for that side tangent.
No, that is a cool side tangent.
It just get all this information about your patient.
Absolutely.
Especially since he had an ablation literally hours before. Okay, needless to say, pacing is a bridge. we are going to stabilize them long enough to figure out what the heck's going on here.
Yeah, we just want their heart to beat enough so that we can get them somewhere where they can figure out a solution.
Absolutely. So when we are going to pace, let's talk about it. Let's talk about how we would do it. I like when we talk about the actual steps to do things on this podcast. So
Me too.
how are we going to set it up?
Well, first and foremost, you have to have your pads on. So pad placement.
Yeah.
Well, you know how I like them.
Were you guys AP homies?
Yeah, I'm an AP homie.
Yeah.
Anecdotally, I think we've had more success with AP.
Yes, I think when you...
Lower amps.
Yes, when you are pacing, I think AP placement... Honestly, I think AP placement is the best all the time. It's just not always super feasible.
Yeah.
But yeah, if you can go AP, do it. If you cannot, then go ahead and put your pads in your normal anterior lateral.
Mm-hmm. And then, like Jamie mentioned earlier, anytime that you are pacing, you need to have your 3 lead on as well.
Mm-hmm.
And then we get into your monitor. So I think this is pretty universal. Do all monitors have like a pacer button? I know Zols do. I know LifePaks do.
Yeah, I think they pretty much all do.
I would say generally there's going to be some kind of very obvious.
Yeah, they normally don't make it to where you have to go like into a mode. Yeah.
Could you imagine? That'd be terrible.
It would be rude.
We can't speak for the Tempest. We don't know what's going on there.
It needs to be all separate.
You're right.
Yeah, you have to go find your pacer actually to then Bluetooth it to your monitor.
God.
No, I'm just kidding.
I know she's not.
I'm not.
That is real. It is separate.
Yeah, unfortunately. Okay, so once you have your pad placement on, you have your 3 lead on, you can then turn on your pacer. So typically there's a physical button on the front of your monitor. From there, you will be prompted to set your rate. So this is going to be the rate that your pacer will be pacing your patient at. Typically it starts anywhere from like 70 to 80, and you have the ability to dial that up as high or as low as you see fit. I don't know why you would need to dial it up
crazy amounts.
Anything crazy.
Yeah.
Nor do I know why you would need to dial it down, but you do have that option.
Sure enough.
It's there.
It is there. From there, once you have your rate set, you can start titrating your milliamps. So this is where somebody needs to have a hand on the patient to start palpating a pulse.
And where do you palpate a pulse when you're pacing somebody?
Femoral.
Yes. If you try to palpate a carotid pulse, you will be able to feel the pacer. There's too much artifact to be able to like identify. Get a femoral. I know it's Aki's.
They're dying. They just want you to help them.
Yes, but get a femoral, and ideally, hopefully perfusion, if perfusion is good enough prior, that you'll be able to find one prior to the start of pacing so that you know you have a correct landmark.
Yes.
You need mechanical and electrical. Guys.
Yeah.
What is that one?
So as you start increasing your milliamps, you already have your hand on a pulse. First, you need your electrical capture. And so you will have little pacer spikes. They need to land with your QRS.
And electrical capture does not guarantee perfusion.
No, it does
how
not.
can we guarantee?
So
Obviously, that's just a safe bet, right?
Once you get your electrical capture, you're going to increase like 5 to 10 milliamps above that. And then you're looking for your mechanical capture. So ideally, you still have your hand on the femoral pulse. We still know where it is. And that pulse should match your rate.
Mm-hmm.
And if it does, then you now have mechanical capture. And you're pacing.
And you are pacing.
And you need to keep an eye on that mechanical capture because...
You can lose it.
And you can also have a lot of artifact when you're probably going emergency traffic with this patient.
Mm-hmm.
So...
Yeah, all of your other monitoring tools are going to be really important while you're transporting because remember, your whole monitor is relying on electrical conductivity, and our environment can really mess with that. So your chance of losing mechanical capture is decent. But what other tools do we have that is not just like every 2 minutes blood pressure and trying to identify a femoral pulse when you're driving down the road? End tidal is great. So pay attention to your patient's end tidal because it is a very quick indicator of your perfusion status. So if their blood pressure is falling, you will notice it on your end tidal prior to anything else.
100%.
And I would say until we have a leg strap with a Doppler, which would be my absolute dream. I do want to invent that so bad. Not a Doppler, it's already been done, but the leg strap. This is just what we're going to have to do. We're just going to have to palpate a pulse.
Yeah,
Yeah.
we are.
They need to create some kind of arterial probe. That's not like a full art line.
For real. That'd be so cool.
So now that we have done all the things, and let's just say we have mechanical and electrical capture, our blood pressure is improving, so is our patient's mentation. So how can we make sure that they're more comfortable?
Yeah, you got to start sedating mama.
Absolutely.
And whatever your protocol, now you may not have sedation protocols. You may only have analgesia protocols. Whatever it is that you do have, use that.
Yeah.
Whether that's like,
just caution.
yeah, whether that's 25 mics of fentanyl titrated up or whatever it is, like, just try your best to mitigate the discomfort that they're experiencing.
Absolutely.
As if this call could not get any more stressful, your patient might go from unresponsive, and then you start successfully pacing them, and then they might wake up screaming at you. So just be ready for
This
that.
actually has happened to me.
Yeah, I had a patient wake up and try to rip the pads off because they were being electrocuted and they didn't like it.
Which is fair.
Mm-hmm.
Which is fair.
Oh, well, yeah, for sure.
I had a patient where this was our projectile vomit STEMI.
Oh, yeah.
We could not get mechanical capture at all. And they were altered, but I could not get, like, we went all the way up to 120 milliamps.
Yeah.
And it wasn't doing, his heart was just
Was like-
ischemic as hell.
It said no thank you.
Said, we will not be doing that.
And I think that that's a point that we actually miss a lot, is that ischemia can affect your ability to get mechanical capture.
Yeah, if everything's dead.
Yes, because the heart truly cannot, like, respond to the electrical activity.
Yeah.
And sometimes you don't know that until you try.
I was so fortunate to be close to the hospital.
Right. And sometimes you just don't know that they're that ischemic until you just try to pace.
Yeah.
But I think that we teach, like, bradycardia, symptomatic, pace. Pace will fix every time. And then we get in the field and we're like, oh, actually,
Yeah.
there's like 1,000 reasons why the pacer won't work.
Yeah. Yeah.
Yeah.
Especially the way we do it. Like, we don't have any, like, way to internally pace somebody, right? So, like,
For sure. There's a lot of
we're just doing the
interference
best.
and a lot of issues that can arise.
there's a million things that could affect it.
Yeah. It's very hard to get mechanical capture on people with a large body habitus.
And people who are projectile vomiting.
Mm-hmm. Yeah, it's tough.
I never thought about this, but I wonder how people who have had open heart and their sternal wiring, how that might affect pacing.
Oh.
Would it? Or would it not?
I mean, it's a conduit, so.
But it's stainless. I don't know.
I'm going to go with not enough to make it not feasible. And I bet it would have a lot to do with your pad placement. Because
Yeah,
if
in
it's
that
AP,
situation, do you change that? I don't know. This is all hypothetical. We need to talk to an electrophysiologist.
Yeah. I would think.
Okay, in my brain, what you should do if someone is,
They're going to have a lot of scarring
yeah,
there, too.
if they're like stapled together, I want to go AP, like, as directly on top of the heart as I possibly
Correct.
can. Because in my brain, if I'm doing anterior lateral, that's way more distance and opportunity for the,
And they have been cut open all the way through every single layer. So, like,
Yeah.
going sideways through that seems
Right.
like it
I
could
feel
be.
like the trajectory of travel is less ideal than AP.
I would agree, hypothetically.
Yeah. This is definitely
don't
just a
really know.
guess,
Yeah.
but it makes
Just
more
a
sense to
thought.
me.
Okay, so now that we talked about how we can pace them, what do we do if they have an implanted pacemaker?
Yeah. Well, what do pacemakers even do when they're, like, implanted?
Well, I guess it depends if it's a set or a demand.
Yeah, so you can have a fixed pacer, so it is a set rate. It always paces at that rate. You can have a demand pacer, so it only paces when it's necessary, so if their heart rate falls below a certain rate. But you can also have, like, a dual pacemaker that is both atrial and ventricular paced.
Yeah.
And then you can have both a pacer and a defibrillator.
And now they're coming out with some wild ones that
Yeah.
are, like, you can't even tell.
Yeah, they're like
Mhm.
teeny
I
tiny.
don't.
Yeah,
I
'cause it
honestly
used to
don't
be
like that. I want
always-
to be able to see it.
Yes, you could look at their chest. If they had, like, a square up by, like, normally it's on the left side, they have a pacemaker.
Mhm.
But now,
They're getting incognito.
yeah, they're teeny tiny.
So this is a public service announcement. If you have a pacemaker and it is invisible, you need to tell us.
And wear a
That is
device or wear a
Mhm.
bracelet or something.
Yes. And if somebody
Man.
asks you for your medical history, that does count.
Yes, it counts. Yes, it counts. Oh my
You
God.
had a surgical opening placed.
A machine is
Made.
running your heart. That counts as medical
That
history.
is serious medical
Well,
history.
That's like having an LVAD and being like, this is just a cool vest I like.
Oh my
Not
God.
important.
Okay.
Yes, it is.
I mean, that is kind of like that. That would be crazy.
Right?
Oh,
Like, that's
Lord.
insane.
Okay, so as far as internal pacemakers, they are there to prevent bradycardia.
Yep.
Correct, especially with the demand pacemakers that Jamie just talked about. They do not prevent all arrhythmias. So, like Jamie just said, there are some like dual pacemaker defibrillator devices. Think of it as like you put an AED on a person and it will read that rhythm and it will say shock or not shock, right? It's not going to shock like a flutter or atrial fib or anything like that. It's just big, scary, lethal rhythms, right? And also, surprise, surprise, like all technology, they can fail,
Yeah.
and which is when we will get called. So
Absolutely. And sometimes, especially with defibrillators where they're concerned, people will be repeatedly shocked by their defibrillator and they'll be like, it must be broken. And I'm like, no, bro. You just keep going into VTAC.
You are having
Correct.
dysrhythmia.
Yeah.
yes,
Yeah.
And can people with a pacemaker also go into heart blocks, have STEMIs?
Absolutely.
the
Pacemakers will
things.
fail for very human reasons, even though it's just a device in there, right? Their batteries can die. Which
They're-
usually the modern ones,
Yeah.
I think they're like remotely monitored for that kind of thing. But the leads can move, like we talked about
Yeah.
earlier. Electrolytes can get out of whack.
Mhm.
Even trauma that could somehow disrupt things.
For sure.
Especially things like hyperkalemia, stuff like that. Things that are not just like any other person. Basically, just treat them like any other patient.
Yeah.
If their pacemaker is failing, they need the same type of interventions. Is
For
what
sure.
I'm trying to say.
Okay, so let's say that we get called to a patient who has a pacemaker. We find them to be bradycardic. Again, we're going to go down our whole thing that we've already talked about, like symptomatic versus unsymptomatic. We're going to assess for any poor perfusion and then go forward from there. If you find out that this person does have an internal pacemaker, do not assume that the pacemaker is already working
Yes.
and that you do not need to take further action.
If they look terrible and you then confirm they are bradycardic,
Just ignore that they have a
the
pacemaker.
pacemaker is not doing anything.
Null and void. That warranty is null and void.
Probably for real.
Yes.
Right. So treat your H's and T's best you can. Go through all of your possible causes for bradycardia while you are setting up your
Transcutaneous pacer, because you can use it in the presence of a pacemaker, an internal
Yes.
pacemaker.
Yes, you're not going to break anything.
No. Do not worry about
It's already broken.
Yes. Do not worry about what externally pacing them is going to do to their implanted
They're
pacemaker.
getting a new one.
Because it's clearly not functioning. So that is not your concern.
Correct. Oh, we kind of already did
Not in depth.
that. I mean, we already talked about literally all of that.
Defibrillators.
Yeah.
So what do you do if it's firing and you can tell that they're not? Like it's just going haywire.
Do you have a little magnet?
Do you have a little magnet?
Yeah. The donut magnets that almost everybody has in their truck that they are great for turning your light on and off whenever you have a truck that doesn't have a timing knob. They are actually meant for disabling a defective defibrillator.
So for me, I'm just going to be so real. I'm probably not going to do that unless I call. It might be in the protocol to do that, but that just freaks me out.
Yeah, I think that so
I
if
need to call for help.
Right, so if you find yourself in a situation where you feel as though that their implanted defibrillator is firing inappropriately and they are not going into any kind of concerning or lethal rhythm and it is shocking them anyway, then disabling that defibrillator is the quicker you can do that, the better, because we don't want like an R on T phenomenon here. 'Cause it's not a synchronized cardioversion; it is a
Literally
defibrillation.
defibrillating. Get an
And
image,
call-
send it to
Yep.
medical direction,
Yep.
and say I'm stopping this. Here's why.
Yep, call your medical control, document everything best you can. Yeah, 'cause we don't want that shock landing somewhere it's not supposed to.
So, if you've done all these things, you've paced them. because that was the immediate intervention that needed to be done to help keep them alive. What other things can we add in conjunction with our pacing to help stabilize this patient further?
An epi drip.
I like epi.
Yeah.
That's a good option here.
For sure. It can increase your contractility. It can increase your conductivity. So it's going to help your heart respond to your pacer a lot better. And it'll give them a little boost.
Yeah. So don't forget you have, more than likely, if you don't have protocols, I'm sure you could call for something very simple as to make like a quote-unquote dirty epi drip.
Yeah.
So just know, especially like in that scenario where, you know, maybe you're unable to get capture or something, there are more options beyond electrical intervention.
Yeah. Yeah. If you can't get mechanical capture.
Yeah, sometimes we have push dose pressors if that's an option. Certain ones may be applicable in this situation.
For sure. And another thing that we talk about a lot in our like day-to-day around the truck personal life when it comes to talking about pacing, but we have not mentioned, is guard those pads with your life when you get to the emergency room.
Oh, yeah.
We all know it is just a habit. It is
Had
just
them
the
cut
way.
them before?
Yes, it is just the way that staff is trained.
I
But
don't know why.
they immediately start ripping off everything that is attached to the patient that belongs to EMS, and you need to guard those pads with your life because
And if it does happen or they give you a hard time, please tell your administrators so we
Yes.
can have a training.
yes, that they removed your pads while
The
pacing.
life-saving device.
Right, because sometimes it's a lot of work to get capture.
And also, this would be, in my opinion, that is the equivalent of going in your intubated patient and just
Ripping the tube
ripping
out.
the tube out because you didn't put it there.
So make sure that you advocate for your patient when you end up in these scenarios and do not allow any staff to just like start ripping things off.
Absolutely, because that's the most defeating thing ever, especially when you worked hard for it.
Right, when you finally get mechanical capture and then someone's just like, ewy.
Yeah, please. That same goes for if you are transferring a patient.
Yeah.
If you're transferring a patient that's being placed, it is my habit, which I haven't done a ton of pace transfers, but to place your pads wherever theirs are not.
Mm-hmm.
And more than likely in the hospital, theirs are not going to be, AP, which is good for you.
Yeah.
Because we like AP. So place the pads, get your pacing set up, and depending how brittle this patient is,
Mm-hmm.
do it gently,
Yeah.
carefully,
Yeah.
right? So
And
just
so
be prepared.
that's something I think that is kind of interesting to talk about. How do you transfer pacers? Like if someone is being externally paced and you're transferring them, how do you get from their pacer to yours?
So a lot of people have protocols, but it's also like okay to do two at once.
Mm-hmm.
So if you put yours on, initiate your pacing as appropriate, usually just copy the settings.
Yep.
And then start to turn theirs off.
Yep.
Because it's synchronizing, right? It's knowing exactly where, just like theirs is. So, especially sometimes I've seen patients in the hospital be on demand, which most of the time, generally we do fixed. And that could vary based on your protocol, your region, or if it's a transfer or not. But I will say, unless they're having some kind of issue, just copy everything exactly. Don't even try to mess with that. Don't try to mess with it.
For sure. And one of the big reasons that we do not do demand in the field is because we have so much artifact interference. And so it is not going to be...
You probably will too, especially...
It won't be reliable.
In an aircraft.
For sure. So just stick with your fixed.
We can move on to some scenarios. How about that?
Let's do it.
Let's do it.
You are dispatched for dizziness. Your patient is an 82-year-old male sitting upright on the couch. He tells you, "I just don't feel right. I almost passed out." These are his vitals. Heart rate, 38. His blood pressure is 88/52. His SpO2 is 96%. His skin is pale and cool. His rhythm, you see pace spikes, but a slow ventricular rate.
Pacer spikes that are like consistent with the QRSs?
No, they're just like randomly going.
Okay. Well, first things first. His oxygen is okay right now. So we are going to get him on the monitor as quickly as possible. We're going to I would try to get a 12 lead.
Me too.
It sounds like he's
Especially
still
since he's mentating.
awake and alert and all the things.
And our pressure is, we're hypotensive, but at a reasonable degree.
Yeah.
Like it definitely made us feel like we're going to pass out, but also like it's still perfusing.
Correct.
Yeah.
And like we talked about earlier, while we're doing that, we can also simultaneously be working on access and all of those things. Get a 12 lead, try to figure out what our underlying rhythm is, and then it sounds like we're going to go to pacing.
Right. Why with this patient would you pace him and not try atropine? Because like he's like stable enough, right?
He is stable enough. However, we already have an internal pacemaker that has obviously failed. So, you know, if it ain't broke, don't fix it. Except for it is broke, but fix it with the same parts.
Is this a situation where you might medicate before?
Yeah.
I think so too.
Yeah. I think be a little bit cautious, just depending on what your medication availability is.
Yes. What do you have?
Yeah. Just be mindful of that pressure. But yeah, try to talk him through it, get him medicated. But for me, the pacer spikes without the correlating ventricular activity is exactly what you need to know, that like medication is not really the answer here.
Absolutely.
Pacing is going to be the answer for him.
Which is a bummer because he is just wide awake talking about this predicament of his.
We're chilling, bud.
We are chilling, unfortunately. He's about to be real chilling because we're going to sedate, hopefully.
Right.
Let's do another one. Your next scenario is you get a call for chest pain. It's a middle-aged patient. They are nauseous. Their heart rate is 42. Their blood pressure is 84/48. They're in sinus bradycardia. And you get a 12 lead that shows ST elevation in 2, 3, and AVF.
What is that?
They're awake, talking,
like?
and look rough.
Okay, well, so sorry, sir. You're having a heart attack. I am going to have to probably put some pads on you and probably going to have to face you. But I also don't know what heart attack
Don't you hate when you have to tell someone they're having a heart attack?
Yeah.
No, so
we
I've
don't
never
know.
had to do that.
We don't know.
But it is a really crappy feeling. I'm just like, I'm so sorry. Because they usually ask you. If they just know, they're like, I'm having a heart attack. I'm like, yes, sir. You are.
As a matter of fact,
but we're going to get you to the hospital as soon as we can.
Everyone's biggest fear and concern and why they call 911, that is it happening to you currently.
correct.
Yeah, baby.
Okay, so this person is having an inferior MI. Okay, so we are already hypotensive, and we are bradycardic, classic inferior. We know that this patient has the very high likelihood of decompensation and decompensation quickly.
Yep.
So we're just going to go ahead and put the pads on this feller.
Atropine could help in this scenario,
Yeah.
especially if it's early enough where there's not enough ischemia.
Yeah, we could try to increase our rate because he's not having a like communication issue.
Right. You could. You can consider it.
At the moment, so I'd consider that. I'm going to steer clear of epi to the best of my ability. I do not want to increase the workload on the heart. I'm probably also going to try to do like a fluid bolus. I'm going to be very mindful of my preload. I want to try to get that to a good point.
Yeah, because if you have an inferior MI, there's a good chance they're going to decompensate suddenly.
Yeah. We're really preload dependent, so we want to try to boost that if we can. And then if all else fails, pacey time.
Yeah. You decide to pace a patient.
'Kay.
You're already on scene. All right. The pads are on. The rate is set. Your milliamps, you've increased them. The monitor looks great. Perfect spikes. You got a wide QRS. But when you check a pulse, there's nothing. And you're already at 100 milliamps. What do you want to do next?
Next, we're going to increase our milliamps.
Thanks. I just used that wording to be tricky.
Yep. Yeah, we're going to keep going.
It's okay to have high milliamps.
We're going to keep going upward. Can I identify a pulse in general?
Yes.
Okay, got it.
Dang. That was a good catch.
I know. I was like, are we dead? Okay, yeah, we're going to keep going up.
All right.
And we're going to keep
happens.
trying to get mechanical
You're
capture.
at 140.
Okay. I'm going to start an epi drip.
I think that's good.
Yeah, I'm going to start an epi drip, and we're going to see if we can get that heart to respond a little bit better to that electricity.
All right. You start your epi drip, and you notice that you do have mechanical capture, but you're unable to obtain a blood pressure above 70.
So I'm going to give him a fluid bolus
Yeah.
also at this point.
More than one thing can happen at one time.
Yeah, we're going to throw some volume in there and see what we got.
Your patient is awake and yelling at you now.
Great, we're going to sedate him.
Oh my gosh.
That is a nice one to throw in here, though, just because some big crazy thing is happening doesn't mean other things are not happening
For sure.
alongside. Most of us are dehydrated. Most of our meals and people's.
For sure.
For sure.
Yeah.
So try simple things too if
Mhm.
that is indicated in the situation.
Absolutely. So that's the most realistic version of pacing somebody. It's hard to get capture. It's really hard to get mechanical capture. They probably are volume down.
Yeah.
Epi is always a good option. Like,
We gotta do more than one thing
Yeah.
usually.
yeah, it's normally not as cut and dry. It's just like put on pads, pacing works.
Unfortunately.
Yeah.
So you walk into a house and immediately hear, "It shocked me again."
Oh, no.
Your patient is sitting upright, wide-eyed, anxious, shouting. They tell you it's happened 4 times in the last 10 minutes.
Okay,
Their
we get
vitals. Ready?
ready.
Yeah.
Heart rate. It is between 100 and 120. Their blood pressure is 99/70. Yep. And their rhythm is just sinus.
Tack.
Sinus tack. Depending on how panicked he is.
Yeah.
When he's been shot.
I would
okay.
like a 12 lead.
Yep. Yep.
Your 12 lead shows sinus tack at a rate of 112 in a right bundle branch block.
Can I get a manual blood pressure?
Your manual blood pressure is 112 systolic.
Over what?
I didn't check. I just
Something.
palpated it.
All right, bet.
Okay, crunch
The
numbers
firefighters
again.
in here are yelling.
All right, so our pressure is decent. He's clearly being electrocuted by his defibrillator. Like, first things first, we're gonna get moving. We're gonna get in the truck. We're gonna get in line. We're going to establish some things. We're gonna keep monitoring his heart rhythm.
So what's the emergency here?
A potentially misfiring defibrillator. We have not, honestly, until it tries to shock him again, we
Right.
can't really
We don't
confirm
know.
if it's misfiring or not.
Yeah.
So it's the emergency is either one, he's going into lethal rhythms and he is being shocked out of them by his defibrillator,
Yes.
or he is not, and the defibrillator is shocking him unprompted.
So you are able to watch the monitor while he has firing of his defibrillator, and you see that it happens inappropriately.
Oh my gosh.
This poor guy.
Fetch me my donut.
Where is
Print.
my donut?
Yep. Oh yeah. Big print to justify why you disabled,
And he
disabled.
asks you, why could you be thinking of snacks like at a time like this?
And I said, "Sir, this is an important donut. You're going to thank me in a minute."
yeah.
Yeah, so I'm going to make sure that we can locate our magnet. Also, probably call medical control and just run them through the situation. But I would like to disable this defibrillator. Yeah, good.
Absolutely.
And just have people on board with you and document it best you can, and then wave that bad boy over his chest.
For sure. Just remember the shock of an AICD is not necessarily the problem or whatever. It is just a symptom of either a misfiring or identifying something incorrectly
Mhm.
or actual emergency.
For sure. Now, if you found yourself in that exact same situation, but when it fires, you recognize that it is appropriately firing.
This is a bummer.
It is a bummer drag for him. You can try some antiarrhythmics, but
do
you
that.
are going to not touch that defibrillator.
Yes.
It
And
is
just
doing
put the
its-
pads on just in
yeah.
case for some reason.
For sure.
You
It
gotta
is-
take measures into your own hands.
Yes.
But it is doing its job.
Ward off all the evil spirits,
Mhm,
get an antiarrhythmic, and go to a facility that can,
Interrogate.
yes.
Yeah.
All right. That's pretty much covers our scenarios that you might encounter very vaguely. This is a very nuanced topic, but this is just the skinny. And as always, let's do some trivia.
Yeah.
True or false? A pacemaker will ensure adequate perfusion.
False.
False.
Yeah, those things are just Persnickety. All right, fill in the blank.
Uh-oh.
Atropine works on
Seldom. Hearts.
Muscarinic
yeah,
receptors.
Yeah.
Oh.
M2 receptors.
and high degree blocks are usually wiring problems.
Oh.
So it wouldn't work.
Well, the wires can't.
False. Can't work. Bad juju. Okay. True or false? Electrical capture means mechanical capture.
No.
False.
Please be so pressed about your mechanical capture. I'm serious.
Yes, because you will just be repeatedly electrocuting somebody for literally no reason.
Yeah, that's weird behavior.
That's weird behavior. It's not allowed.
And then next and lastly, you can externally pace a patient with a pacemaker.
True.
Please don't be afraid. You're not going to mess up anything.
Mm-mm.
You're
It's
only
already
gonna
broken.
Hopefully fix things. Yeah, that's really all we got. I hope that you learned something. This is really just the skinny version, a refresher on electrical interventions in the field. As always, treat the patient, not the monitor. Electrical interventions can feel really scary because they're not super common, unless your name's Sophie and all your patients are bradycardic. It's my curse.
Yes, it is.
But don't hesitate. It's okay to put the pads on and dial everything up and then say, oh, we're good now.
Yep.
Be prepared. The only thing you're going to regret is not being prepared, right?
Right.
Correct.
Cool. I hope you learned something and take it easy, but not bradycardic easy.
This has been Life in Sirens, produced by 3 nerds trying to bring you content that you might actually care about.